Hi, and welcome to today's presentation. I'm Ryan Perdilia, an acute care nurse practitioner student from UT Health Houston. And my presentation is all about basic POCUS, or point of care ultrasound, to assess left ventricular systolic function. The objectives of this presentation includes to briefly discuss the necessity of POCUS skills for APPs. Next is to discuss heart failure and left ventricular ejection fraction. Also, we want to discuss indications for POCUS, cardiac ultrasound, and then we also want to do quick review of ultrasound. Next is most common views for cardiac POCUS. Next is qualitative assessment of left ventricular ejection fraction, and then ultrasound images of various left ventricular ejection fraction percentage, and lastly, billing and coding of cardiac POCUS. POCUS skills is an expected fundamental competency for advanced practice providers in the emergency department to aid in faster diagnosis and management of unstable patients. In fact, the American College of Emergency Physicians and Society of Emergency Medical Physician Assistants endorse the use of POCUS by advanced practice providers. And this endorsement highlights the importance of POCUS skills. Arguably, NPs in any acute care setting can benefit from being skilled in POCUS in order to better respond to patients in acute decompensation, such as those in cardiac arrest or hemodynamic instability. So let's talk about heart failure and its relationship to left ventricular fraction. All right, so let's talk about heart failure. Heart failure is a condition in which the heart is unable to pump enough blood to meet the body's metabolic needs. And this causes decreased cardiac output and congestion in the vasculature and resulting to fluid accumulation, or what we call edema. And this happened because the heart is weakened by, let's say, myocardial infarction or hypertension for chronic period of time. For systolic heart failure or heart failure with reduced ejection fraction or HF-REF, common symptoms include shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, exercise intolerance, irregular heartbeats, and edema in bilateral upper and lower extremities. And one way to diagnose heart failure is when there is a decreased ejection fraction, which can be measured with the use of cardiac ultrasound. So the most widely used test to assess the systolic function of a heart or left ventricular ejection fraction is with the ultrasound of the heart, or commonly called echocardiogram. So let's talk about ejection fraction. It is the percentage of the blood pumped by left ventricle with each contraction. And factors that affect ejection fraction include preload, afterload, and contractility, which those are you can look those up. So basically, ejection fraction is a percentage of how much blood the left ventricle pumps out with each contraction. For example, if you look at the chart, the normal values is 55 to 69%. So if the ejection fraction is 60%, that means that 60% of the blood, or 60% of the total amount of blood in the left ventricle is pushed out during each systolic contraction. And in these values, I will show these ejection fraction values, how they look like in the ultrasound, towards the end of the presentation. More information about ejection fraction. We use it to evaluate heart's efficiency in pumping blood, as in the case of heart failure. We also use it to monitor disease progression, risk management or risk assessment, and guiding treatment decision. And lastly, as a preoperative assessment, for example, in CABG procedures. Moving on, let's discuss the indications for bedside cardiac point of care ultrasound, specifically when we want to assess left ventricular systolic function. So this diagnostic procedure is very important because it allows rapid assessment of the heart's function and structure at the bedside, resulting in timely diagnosis and management, which is very important for crashing patients. In order to illustrate the utility of POCUS ultrasound, let's discuss a case study. A 65-year-old patient who is known to have heart failure came in due to cellulitis and DVT in the left lower extremity. He suddenly became short of breath, hypotensive, and unresponsive, raising your suspicion of pulmonary embolism, sepsis, or cardiogenic shock. In this case, we can use POCUS to identify whether the shock is cardiac or non-cardiac in nature. So on your ultrasound, cardiac cause shows hypocontractile left ventricle indicative of decompensated chronic heart failure. On the other hand, obstructive causes such as pulmonary embolism will result in hypercontractile but empty left ventricles. Now let's talk about the advantages and disadvantages of POCUS echocardiogram. For the advantages, it is fast and immediate results, non-invasive exam, dynamic assessment or real-time imaging, and lastly, it can be used for serial monitoring. For the disadvantages, on the other hand, it is highly user-dependent and does not provide quantitative analysis. So let's do a quick review of how ultrasound works. So ultrasound is high-frequency sound waves that are transmitted from a transducer, and then these sound waves are then reflected by different tissue types in different ways. And then the reflected sound waves are then picked up by the ultrasound transducer, and then the sound waves are then transformed into image by special software. How do tissue types differ in their reflection of sound waves? For bones, fat, and stones, they can be hyperechoic signal, and they are bright as most ultrasound waves are reflected back. And then for cartilage and muscle, they are hypoechoic signal, and they appear dark as most waves pass through the tissues. And then for fluids and fluid-filled structures, they are anechoic, and they appear as black as there is no reflection of ultrasound waves. And for others, a shadow may be noted on an ultrasound when a hypoechoic area is located behind a hyperechoic structure. There are different types of ultrasound probe, but for cardiac ultrasound, we specifically use what's called phased array or sector ultrasound probe because they are smaller and flat footprint allows you to be able to fit in between the ribs to easily visualize the heart. In order to assess for left ventricular ejection fraction, the most common views that is used are parasternal long axis view or PSLA, parasternal short axis view or PSSA, apical four chamber view or A4C. Let's start with the parasternal long axis view. It is usually the first cardiac view obtained and will give you an immediate assessment of the general condition of the heart, including the ejection fraction and overall left and ventricular sizes. So how do we do the parasternal long axis view? We do it by placing the probe at the left sternal border in the left third to fourth intercostal space. And the marker of the probe should be directed towards the right shoulder. If you look at the picture on the left, where you can see the green arrow, it's pointing to the right shoulder. Okay, so let's see how that looks from this video.
The marker of the probe should be pointed towards the patient's right shoulder. Going ahead and place my probe here. And so here we can see a very nice parasternal long view. We can see the left atrium, the mitral valve, the left ventricle, the aortic valve, and towards the top we can see the the right ventricle as well.
So using the parasternal long axis view, you should be able to identify the right ventricle, the left ventricle, the left atrium, the aortic valve, mitral valve, aorta, descending aorta, and the pericardium. If you look at the picture on the left, you would see the aorta on the top, the right ventricle, the left ventricle, the left atrium, and the descending aorta. And on the right side of the screen shows an ultrasound view of a parasternal long axis ultrasound view. Again, you would see the aorta, aortic valve, the left atrium, the descending aorta, the pericardium, the mitral valve, left ventricles. The most important structure that we want to look are the mitral valve and the left ventricles. The next view is a parasternal short axis view. So from the parasternal long axis view, we want to rotate the transducer or the probe 90 degrees clockwise so that the indicator now points towards the patient's left shoulder. So let's see how that is done in the next video.
Okay, so now we've done the parasternal long, let's transition to a parasternal short. A parasternal short is a great image to look at cardiac function, particularly systolic function of the left ventricle, the right ventricle, as well as evaluation of the mitral valve. So let's talk about the parasternal short. If you're in a parasternal long, it's actually quite easy to get parasternal short. You don't need to lift up the probe. All you need to do is just rotate the probe about 60 to 90 degrees, and you'll be able to get the image. What I do is I use two hands. So I keep one of my hands firmly anchored on the patient, and I simply rotate the probe about 60 degrees, so now it's pointed toward the patient's left clavicle or left shoulder. When I do this, I'm able to see a short axis view of the heart.
So the parasternal short axis view provides a cross section of the heart, and it should be obtained at the level of the papillary muscle. And this view provides an assessment of left ventricular size and function. Also, we can also assess the right ventricular size and function, the aortic valve as well as the mitral valve, as well as the presence of wall motion abnormalities. The next view that we will be discussing is the apical 4-chamber view. Apical 4-chamber view is some of the most important view to be able to obtain when doing hemodynamic assessment of the heart. And this includes looking at the diastolic dysfunction, which is not covered in this presentation. It's also able to determine valvular regurgitation as well as cardiac output, to name a few. Unfortunately, it can be one of the most challenging view to obtain for novice practitioners. So let's see how apical 4-chamber view is done.
Let's go ahead and transition to the apical 4-chamber view. There's a couple of things to keep in mind when doing an apical 4-chamber view. First, it's one of the more challenging views to obtain, so this might be the one where you're going to have to turn the patient onto the left side. Another thing is if you're having a patient who has substantial breast tissue, you're going to want to lift the breast and scan in the axillary fold. Never scan over the breast. Another thing is sometimes you can attempt to find the point of maximal impulse, or PMI, and that's generally the spot where you're going to want to place your probe. The apical 4-chamber, as a general view, is quite good at visualizing all 4 chambers of the heart, evaluation of systolic function, as well as looking at the mitral and tricuspid valves. When I'm thinking about my apical 4-chamber view, I'm generally going to be a little bit lateral to my midclavicular line, and I'm going to place my probe just inferior to the nipple. If you have a patient with really substantial systolic disease, their heart might be a little bit more laterally displaced, and you have to accompany that. Thinking about my patient here, I have my apical 4-chamber. Generally, you're going to have to increase your depth as you're scanning. In this particular view, we can see the left ventricle, the left atrium, the right ventricle, and the right atrium. One of the confusing things is for this particular view, everything is switched. The left is on the right side, the right is on the left.
When doing the apical four-chamber view, we're able to identify the left ventricle, the right ventricle, the left atrium, the right atrium, the tricuspid valve, and the mitral valve. The image or the video on the right side shows an echocardiogram of apical four-chamber view. So this presentation is focused more on qualitative left ventricular function assessment. So when we talk about qualitative approach to assessing left ventricular systolic function or ejection fraction, basically it's a visual estimation of the left ventricular systolic function or ejection fraction. So it is a way to rapidly assess the systolic function to determine whether the cause of, for example, hemodynamic instability or shock is cardiac in nature. And as it turns out, the qualitative point of care ultrasound or POCUS evaluation of ejection fraction shows relatively strong correlation with formal echocardiograms, which is the usual practice. So to assess left ventricular ejection fraction qualitatively, we make observation about both the left ventricles and the mitral valve movement. So initially, as a novice POCUS cardiac ultrasound practitioner, your goal is to be able to recognize whether the left ventricular ejection fraction is severely depressed or when it's not, which would tell if the hemodynamic instability is non-cardiac in nature. That is something that we will discuss in the next slides. So the clinical questions that we want to ask when doing qualitative approach to assessing left ventricular ejection fractions are, first, are the left ventricular walls coming close to each other during the diastole? And the next one is the mitral valve leaflet moving close to the intraventricular septum during diastole, or what they call septal slap? So if the left ventricular walls are moving close together during systole, and if the mitral valve leaflet is almost touching the septum during diastole, then the ejection fraction most likely is normal. So let's see how that looks like in parasternal long axis view. Again, we are looking at the left ventricular wall movement and the anterior mitral valve leaflet movement.
So we identify the myocardial wall that we see here, and we're going to pay attention to how much that comes close together or comes together when evaluating this. In addition to doing that, another trick you can do is look at the anterior mitral valve leaflet and how well it approximates the septal wall of the left ventricle. If the anterior mitral valve leaflet is hitting up against the mitral wall in the initial filling of the left ventricle, then the odds are that your ejection fraction is normal or in the normal range. Now, obviously, this can be difficult to interpret in patients with arrhythmia or tachycardia, and was limited by people with mitral stenosis and or aortic valve regurgitation. So take it with a grain of salt, but that's what you can do. And so when we look at this example, we have both normal cardiac function and a severely reduced. We can see that those myocardial walls of the left ventricle are really coming together. They're almost kissing in this example. And then we compare that to on the right in the severely reduced EF. We can see that those myocardial walls are really not moving very well towards each other. And then when we look at the mitral valve in both of them, the mitral valve on the right image in the severely reduced is just barely opening. Whereas if you pay attention, you can see that mitral valve leaflet coming really close to the septum right here. And you can see it just flipping up and hitting right there initially. It does come down, it goes up, hits the walls, come down a little bit, and then you get your active phase of the left atria, and that will do some, known as your atrial kick, and that will fill the left ventricle.
We can also assess the left ventricular function qualitatively using parasternal short axis view. So the way we do it is we obtain the PSSA view on the mid-papillary level, and we need to observe the cardiac muscle in a similar fashion as the PSLA view. We need to ensure that all sides of the wall are moving inward equally. In the next video, we will see in more details how that is done.
Now, on the left, again, we're going to see our normal function. This is very good collapse. It's a little bit of a limited view, but these are the same patient throughout this. And so although this is not as an ideal view, we can see here that the ejection fraction looks good, or the function looks good. Compared to on the right, we can see that the left ventricle is not collapsing very well, that the myocardial is not coming into the center. Now that view is a little off plane, but still gives us an idea of what's happening there.
Now that we're more familiar with the visual or qualitative assessment of left ventricular systolic function, let's see how various ejection fraction percentage compared to normal EF looks like. In this slide, we are looking at the hyperdynamic ejection fraction, which gives about 70% ejection fraction. On the right side, we are looking at the mildly reduced ejection fraction, which is about 45 to 54% ejection fraction. And we are comparing it to the normal ejection fraction on the left side of the screen. On the right side, we are looking at the moderately reduced ejection fraction. When we say moderately reduced, it's about 30 to 44% ejection fraction. Lastly, we're looking at the severely reduced ejection fraction, which is about 30%. You can see that the ventricular walls are very far from each other. Therefore, there's a decreased cardiac output. And then most of the blood are staying in the left ventricle. For the ultrasound CPT code that we use to bill insurers, we would use 93308, which is echocardiography, transthoracic, real-time with image documentation, includes M mode, recording while performing, follow-up or limited. And finally, this last slide shows all the references that we use for the presentation. And with that, thank you so much for your time and have a good day.